Hello friends, I welcome you all to the October issue of the Indian Journal of Anaesthesia Authors Podcast, and I want you all to join me in welcoming my new co-host, Dr. Karthik. He is an anesthesiologist who works at AIG Hospital in Hyderabad. Dr. Karthik, welcome to the podcast.
Thank you so much. I'm feeling very privileged to be here with you all today. Thank you.
And we are honored to have you with us as well. So, as usual, like in every episode, we've got three very interesting articles this time, and we've got three very interesting authors who are in our podcast today as guests. And I'm going to call the first author in. We're going to discuss their work on does the resistive index of the radial artery change after radial cannulation in patients undergoing abdominal surgery, which is a prospective observational study. And to talk about this, we have the author, Dr. Lakshmi Kumar, who is a professor and head, Department of Anaesthesia, Amrita Institute of Medical Sciences, Kochi. Dr. Lakshmi, it's an honor and privilege to have you with us in the podcast.
Thank you. I'm privileged to be part of this and happy to meet all of you for this interaction.
So, Dr. Lakshmi, I was just going through your article, and for a minute before I started reading the article, I said, I don't know what this is about. I really want to talk about this. So what practical concerns or challenges in the perioperative period led you to study the resistive index of the radial artery after cannulation?
So I happen to work in a center where arterial lines are a norm. Almost 80% of patients undergoing the kind of surgery they do have an arterial line. And when the patients come back, say 3 days later, 5 days later for a resurgery, and you palpate the artery on that side, we found it was feeble. So we knew that there was something related to the cannulation, our flushes, whatever, that was making the artery more feeble. We would either avoid that site or go higher up. So we wondered to see if radiologically we could observe changes. My impression was that when I'm going to do the ultrasound after taking out the cannula, the artery is going to be smaller. That was the hypothesis with which we started, but we came up with a different set of results. And of course, there were challenges in doing it, a lot of challenges in doing it.
So for our listeners, many of whom may not be familiar with, like me, who are not familiar with this concept, could you briefly explain what the resistive index is and how do we measure it? And why is it important for anesthesiologists to pay attention to it after arterial cannulation?
So, Gayatri, I must confess that a portion why we moved to this is we were running short of topics for research, and I am committed to run about anywhere from 2 to 5 research projects a year. So this came up because I wanted to diversify the topics. You can't go on investigating propofol and ketamine. So coming to what the resistive index is, it's actually the radiologist's terrain. When you place a probe across the radial artery, different arteries have different profiles of arterial flow. So when you see the arterial wave go up and come down, you have something that is called the peak systolic, and then you have an end diastolic. It comes as a second hump. It doesn't look like the arterial trace that is shown in pictures, but it comes as one and then as a second kind of curve that you might see. So the resistive index is a radiological calculation which it comes from the machine once you focus on the peak systolic and the end diastolic. So peak systolic minus end diastolic divided by the peak systolic is what is called as a resistive index. It is the most commonly used index for the assessment of flow through the arteries. You'll find when we do transplants, either renal or liver, the radiologist will do his Doppler and comment on what is called the resistive index. So a certain value of resistive index, say between 0.5, 0.6 to about 0.9 is considered normal. Lesser and higher is considered abnormal. Like in our study, we noticed that if the diastolic velocity was on the same side of the arterial trace, it meant that the resistive index was normal. And if it crossed over to the opposite side, it meant that the resistive index was high. I hope that makes sense.
Yes, beginning to make sense. So, what were the most important findings from your research? And was there anything that really surprised you or that might change the way we anesthesiologists approach radial artery cannulation or arterial cannulations as such in the future?
Right. So I just want to say that when you cannulate, however kind or good you are while cannulating, there is a certain amount of trauma that you introduce by passing a cannula right in. And that actually comes as a change in the pattern of flow. So I have actually mentioned this in my limitations of the study because I'm not a radiologist. So we started measuring the resistive index. And when we did our study, we looked at it at the point of insertion, a point 4 centimeters higher to the point of insertion, and on the ipsilateral ulnar artery of the same hand. So, when you measure the resistive index after taking out the cannula, the flaw of the study was that you measure the resistive index at a point where you find the flow, like when you keep a probe on the longitudinal axis of the artery where you get the color, that's where you will be able to get a resistive index. So if the flow was actually speckled, I didn't have a fallout to go and measure because you will not get a reading of the resistive index at that site. So we actually only measured the resistive index when we got, even though we knew that the flow was a little speckle, that's a terminology which I want to use because it's exactly how it was. But we did find in the study that although we didn't document changes in the radial artery, the ipsilateral ulnar artery showed an increase in size as well as flow. And we hypothesized that there was some compensation for flow occurring in this radial and ulnar. So when the radial decreased, the ulnar was compensating. So this was similar to another study that was published earlier, and it just highlights the fact that your arterial cannulation has the potential to cause some changes in flow, and we need to be cautious and aware of this.
Is there any, different, is there any techniques or did you kind of see what kind of techniques cause more change in resistive index or the way we cannulate? Does that make a difference in?
We did not find any literature to support it. So ours is also a large volume center. So the cannulation was done by anybody who had training for more than a year. So I think a few used transfixation. Otherwise, it was just hitting the artery, flattening the needle and advancing the cannula. I'm not sure if the technique actually contributed, but we did not use an ultrasound because of the availability, and we excluded patients who needed more than 2 cannulations. So if trauma was related to it, it was excluded in this study.
Is this a permanent change? Like, do you think if we measure this later on after like a couple of months, it's going to come back to normal? Or?
I feel that it would have returned to normal, and the original study had actually planned to look at that. But the logistics of getting the patient at the time of discharge or when he comes for a review was formidable that we were not able to pursue it. So all we could do was 6 hours after decannulation. The original study was meant to look at it at 10 days and then at a month. We could not do it.
So now, based on your study, Dr. Lakshmi, what do you think the next steps are? Like, how could future studies build on this work, and what advice would you give to anesthesiologists considering using the resistive index in their practice?
I'm not sure if I would just say use an ultrasound and look at the resistive index, but I think they could be more aware of the attempts when you're giving the artery. And my future study probably would look at the flow pattern rather than the resistive index. We use the resistive index because that was the only described parameter for assessment of flow. But I think if you get some kind of laminar versus a turbulent flow, you could probably say that the arterial cannulation caused this, and that may be another index of assessment.
Thank you so much, Dr. Lakshmi. It's
Thank
always
you.
amazing to see new titles on the journal, and then it piques everyone's curiosity, and we really wanted to get you into the podcast to discuss this topic with you. Thank you so much for spending your valuable time with us.
It was my pleasure. Thank you.
So friends, next we have a true guest in our podcast today, and that's Dr. Ismiarti Shariffuddin. She's a consultant anesthesiologist who works at the University of Malaya, Malaysia. And she's here to talk to us about her article, which is a quality improvement project titled Medication Stewardship in the Operating Theatres in Malaysia. Dr. Ina, welcome to the podcast of the Indian Journal of Anaesthesia.
Hello everyone, thank you Gayatri and Indian Journal of Anaesthesia for this invitation. I felt very honored to share my paper with all of you.
So Dr. Ina, it was really interesting to read your paper on medication safety. I want to begin by asking what were the primary safety and operational concerns around medication management within your operation theatres that led to the launch of this project?
Okay, our center is a tertiary center, Gayatri. So we receive new medical officer trainees every 6 months. Hence, we need to have a good guideline for every 3 months. So every 6 months when the changing occurs, so that everybody are always on the same page. However, one of the new months that they came, we had a near miss in our center. We had a drug error near miss, which Alhamdulillah, it didn't cause any harm to the patient, but it was giving no adrenaline instead of atricurium to the patient. So our medical officer was waiting to intubate the patient, but the patient never went to be relaxed. When we checked again, she gave no adrenaline instead of atricurium because it was look alike. So hence then we decided as a team to look back at our practice and then see how we can improve our working environment so that this near miss didn't occur again. So while we are doing the same thing on looking at our drug management, we also had been getting feedback from our sister management of the OT management, saying that there's a lot of drug wastage at the end of the day, especially all our vasopressors, ephedrine, atropine, and also propofol. So this was going to cost us a lot of money. Hence, at the same time, while we are auditing our management of drugs in OT, we carry on to look into drug wastage as well.
This is absolutely true. I think it's true everywhere where anesthesia is practiced and there are a lot of students coming in. It's very difficult to keep tabs on what everyone's doing, and it's really interesting that you even looked at the wastage of medication, which I'm sure all of us are facing. So Dr. Ina, what specific strategies and interventions did your team implement during this project? And I read that you talk about the plan, do, study, act cycle. So can you elaborate a little on your methodology from that aspect?
All right, for this study, we do the PDSA, plan, do, study and take the action. For the plan, we wanted to know whether our trainees know, first of all, what are the costs of the drug that they use every day, because when you don't know, you tend to waste things. So we did a survey to see whether they know the cost of the drug. We put all the usual drug that we use, and we asked them to put the range of price that they thought it is. And then we compare it to the list that is given to us by the pharmacist, and then we see whether that's accurate or not. And then secondly, we also did a pre-intervention survey on what is all the trainees' perception of medication error. Have all of them met with medication error? And surprisingly, about 84% of them said they have medication error, So either they report it or not, that's a different thing. But because this questionnaire was anonymous, so people were telling the truth in what they have experienced, both in the cost of the price of the medication and also the event that occur around medication error. So, and then when we know this, then we did the planning. What we did next was we thought education is very important. So we planned several intervention when we have noted what is the problem. So we plan intervention in a way that first, because it's trainee from all over Malaysia that comes to our center. So we standardize our drug preparation. Okay, so what we didn't touch was the cardiac and pediatric OT because it's separate away from our main block. So all the rest we standardize and we make a list of the drugs that need to be diluted as required, and then what drugs that only should be diluted. We don't want them to waste their drugs. Okay, and then we make videos on how best to the drug protocols to look after drugs in our center. We prepare a tray and how this tray should look like, and all that is in recorded, so that when new trainee comes, we don't have to repeat it. They can actually just look at this video and understand the protocol that we're adhering to. And then we also make a drug registry. This drug registry is just a simple drug registry. It's in the form of Google form. So if there's any adverse event or allergic reaction that occurs, we want them to report immediately without feeling the fear to be blamed that they have done certain mistakes, especially when reporting about drug event. So that's the D part, the do part. And then we do the study. After we did all this, then we did the post and we intervene again and ask them the question. And we dedicate a group of nurses to just look at the drug wastage every day. At the end of the day, they will look from every OT and check how much of the drugs being wastage and calculate it and put it into an Excel form. And we then calculate it again at the end of 3 months. And then after that, we also see whether there's any drug error or near misses throughout that operation. So that is the S part. And then at the end, we integrate the act part. We integrate all the successful thing into routine protocol, so that when every time there's a new student that comes, they know where to get the information and they know how to do it in OT. Yeah, so
That's
that's
very
all.
interesting. That's very interesting, and I love the fact that you made videos for educating the trainees. So, what were the most significant, measurable improvements you observed while following following the implementation of this program?
Of course, first of all, is patient safety, right? From the 3 months, we know that near misses are not a frequent thing, but in that 3 months, we did not have any drug error, and amazingly, the wastage is very, very much reduced. In that 3 months, when we did the study, we managed to save about 5,000, it's 4,000 plus, near 5,000 Malaysian ringgit, just within the 3 months. And you can imagine if we were to do that over a period of year, it will cost more savings, Ideally, of course, this could be done in a more high technology way, like you have a GA, a portable working station that you can just scan the bar and you don't waste the drugs. You know the drugs you're going to give. But coming from a middle income country, that doesn't seems to be very easy for us. The economy is not there for us, So this way we manage to control our wastage, and at the same time, the most important thing, the patient safety is prevail. One of our major finding that we found in this study was they have the error because they were working in a chaotic and fatigue environment. So what we did in one of our action is for them to not be disturbed. When one person is diluting the drug, they shouldn't be disturbed. And after they dilute, they should have another. Normally, we have 2 medical officer in one operating theatre, and after that, the other medical officer will check that the dilution is the same as and label accordingly. So color coded label is very important, because then you have all your visual acuity to reduce unnecessary mistake. Yeah.
Yes, I particularly find the color coded labels very good, and I always encourage. So they still take white stickers and try to write the names down, but I always say when it's available, why don't you just use them, because it just you know, it's just so obvious, so visible what you're using. Okay, so you said that you had nurses checking up, keeping an inventory about the wastage. So there seems to be some kind of an interdisciplinary collaboration in achieving the goals of this project. So can you share insights into how anesthesiologists, nurses, and pharmacologists worked together to improve medication practice? Can work together to improve medication practices?
So in this particular audit, the nurses were asked to, as I mentioned, were asked to look at all the wastage at the end of the day, and then they will put it into an Excel sheet, and then we calculate it at the end of the week or the month of how much wastage. And what happened following that is, the drug that we're going to bring into operating theatre are also indented by the anesthetic nurse, right? They are the one who making the orders from pharmacies. So we also ask them to then check whether after we implemented this protocol, whether there's a reduction in the numbering of the drug orders, in the volume of drugs. And we noted there was a reduction in volume, like reduction in in the muscle relaxant, in atropine. They don't need to order every weekly as much. Instead, some of it was prolonged to every fortnight. And pharmacies came into this just to confirm that yes, the ordering has been reduced, and they then translate how much that reduction has saved us. So they help us in that way.
So, Dr. Ina, we always say too many cooks spoil the broth. So, when there are so many people involved in the project, how did you ensure consistent participation and compliance from all the involved stakeholders?
It's very difficult. It's a lot of teamwork, And in anesthesiology, it's never a work of one person. So being a team, we need to have team leaders in every section. So when we're communicating with the medical officers, so I have one of my specialists who helm that project just to ensure education, and they understand the drug dilution, the importance of labeling and all that. So we have a team that just look after that CME program. And then for the nurse, we need to get buy-in from their top nursing, from the matron. And when they follow their leader, and when they understand the impact of this drug error and drug wastage, because when we had our M&M, we call them in and we show them that how bad it is when this error comes. So the leader understood this impact, and then they help us to translate it into the other nurses. And we again had a team who looked into educating the nurses, a continuous nursing education. So we gave about a week of how we should look into the drugs, how we should not, the importance of not causing near misses and drug wastage. So education and a team leader in every plan was very important.
I'm so glad that you had everything, you had anticipated everything and you had all systems in place to make sure that your project goes on smoothly. So, Dr. Ina, I must really thank you. I think, even other countries and hospitals looking at improving their medication management system can take away so many important points from this project. Thank you once again for joining us on the IJA podcast. It was really, really good to have you here. And I love the way you planned your project and kept all the reportings anonymous, because most often people find it difficult to report because they're scared of what the consequences are going to be. So thank you very much for your insights. It was a pleasure to have you with us.
Thank you for the invitation, Gayatri and IJA. Thank you so much for publishing for us as well.
All right, so the next article that we have chosen is a systematic review and meta-analysis titled Bridging the Pain Gap After the Cancer Surgery and Evaluating the Feasibility of the Transitional Pain Service to Prevent Persistent Post-Surgical Pain. We call it PPSP. Honestly, this was the most interesting article that I have found in the recent journal. And to deep dive about this, we have with us Dr. Raghu Thota, who is an expert in palliative care and pain management, and he currently serves as a professor and consultant in palliative medicine at Tata Memorial Hospital and Homi Bhabha National Institute. Dr. Raghu, thank you so much for joining us today.
Thank you and namaskaram to everyone and happy Navratri to all.
Yeah, thank you so much, sir. So, Dr. Raghu, to begin with, could you explain what actually a transitional pain service is and what is the pain gap that it is actually trying to bridge? For a layman, how would you describe a transitional pain service?
Certainly, this seems to be a very new topic, I can say, a novice topic in our country, especially the transitional pain service. There are very well established these services, especially in Canadian regions. So, coming to what exactly is a transitional pain service, so we can say it is a specialized healthcare service, so which is actually designed to manage and support the pain of the patients which they experience it during the critical transition period, we can call it as. So the typical transition period usually happens uh, from the acute phase, such as following a surgery, or to a more stable, or I can say a long-term management plans. So the goal of this transitional pain service is usually to ensure a smooth and effective transition in pain management strategies. So particularly in individuals who are at a high risk of developing chronic pain. So this is what exactly is a transitional pain service. And coming to what exactly to understand is a pain gap, which we are trying to bridge it between the acute pain and patient developing a persistent post-surgical pain, right? So this actually the goal is to bridge it, right? So there is a pain gap. So acute pain progressing to persistent pain and transitioning into chronic pain. So there is not only pain gap, there is also a period gap. We call it as something called. So the hospital care progressing to the home care and then transitioning back to the transitional pain team. So if they develop into persistent post-surgical pain. So these two gaps we have to bridge and we have to provide a continuum of care so that the patients can have a good quality of life and their pain.
So, by the brief introduction that you gave, I understand that persistent post surgical pain or PPSP is really a significant issue.
Yeah.
Sir, could you share with our listeners the main risk factors for developing PPSP and particularly in cancer surgery, how the patients are going to get affected by post surgical pain?
Absolutely, absolutely. So it is actually a very serious, and I can say that it is often an under recognized issue. See, because most of the patients may not come and present to you, especially post mastectomy pain syndrome. Okay, they just undergo the surgery and they accept it. If they have a chronic pain, if they develop it, they will not attribute it to that surgical thing. They attribute it to the disease aspect itself, and they accept it. So usually the reporting is very less. So I will say it is under recognized issue, and particularly in the context of cancer surgeries. And I would like to highlight is that the persistent post-surgical pain, it usually develops after the surgery and usually lasts more than 3 months, and that is what we usually define persistent post-surgical pain. So when it comes to the cancer surgeries, there are multiple risk factors which uh, cause or develop PPSP or the persistent post-surgical pain, I can call, and it can be because of the surgery itself, it can be because of the disease process itself, or it is individualized patient factors which can cause. But there are certain key risk factors, especially in cancer patients. So I can say because of the cancer disease, which itself is a very invasive disease. Okay, it invades most of the nerves, it infiltrates, so that itself is a risk factor. And also when we operate, it's a nerve damaging surgery because it is invaded to most of the soft tissues. Again, most of these patients, if you see 60% of these patients, when they present to a cancer institute, they present with the pain, and that is how we diagnose and we try to evaluate and come to know that they are suffering from cancer. So there is always a pre-existing cancer related pain. Then again, there is a lot of psychological distress because the cancer word itself is so disturbing to not only the patient but as well as the family members and the caregivers. Even certain therapies like chemotherapy or the radiotherapy also causes nerve damages and cause neuropathies. Even that also add on to the risk factors. And another thing I would like to add is there is I'm not so don't get offended, but there is a inadequate post-operative pain control that also adds on to the risk factors of developing PPSP, particularly in cancer surgical patients. And again, I can say the gender issues. So these are certain key risk factors which can cause or develop PPSP in cancer surgeons.
Okay, sir. I'm able to understand. So the pain mainly we are dealing is with the post-surgical pain, but I would like to know: is there any role of early intervention in preventing the post-surgical pain, and how does the team of transitional pain services team, how do they facilitate this process of prevention of this PPSP in the future?
Yes, yes, true. There is actually a huge role of early interventions, not grow only pre-operative, intraoperative, even the post-operative interventions help in preventing PPSPs. So they play a very crucial role, and so most important thing is that you have to address the pain early. Okay, that is becomes very very important. If you're addressing the pain very early, it can reduce the risk of it becoming chronic. Pain modulation is one of the things. So second thing is personalized pain management. You go and talk to the patient, and there are certain patients who have a high threshold, certain patients who have a low threshold to these things. So that things we really need to take care into. Again, they may have certain comorbidities which can help, may not help us to put certain interventions in that particular group of patients, especially if you ask liver surgeries where it is a major risk, major surgery or a supra major surgery, they may have massive blood loss. So in such patients, it is difficult to get epidural in place because they may have a post-operative coagulopathy and it becomes difficult to manage the epidural catheter post-operatively because of the coagulopathy. So personalized pain management has to be developed before inducing the case. We have to go and visit these patients, and also we have to prevent the central sensitization. This is very important because the chronic pain is mainly because of this sensitization, not only at the central level in the brain, but at the DRG level, at the spinal level, and at the local level of the receptors also. So this we can do it by adequate pain control again, and we have to employ something called as I can say a multimodal analgesia. It's not only one form of intervention. That either a pharmacological, especially an NSAID or an opioid, we have to look into other modes of analgesias also. We have to add into it. It is not only one mode of analgesia. So we can either use an IVPCA with epidural analgesia. So what I used to do is that most of the patients, especially the thoracic patients, surgical TTs. We used to put a epidural as well as we used to give them an IVPCA. That helps on a lot because most of the times in the early morning, the physiotherapist comes and make them do intensive physiotherapy and they have these acute episodes of pain. So IVPCA really takes care of that. Episode. So multimodal analgesia becomes an important. So not only that, in spite of having an epidural analgesia, we can also give something called as skin infiltrations or local infiltrations. Even that also helps. So all these things are very very important, and I can say these are the interventions which can prevent PPSP. And coming to the role of transitional pain services, how they can help here is that we have to do a comprehensive assessment. So the comprehensive assessment is not only the physical assessment of the patient; it includes a lot of psychological and social factors which contribute to the pain, and then it also includes a multidisciplinary approach. So it is not only the anesthesiologist and the pain physicians who will be visiting. I can say the patient. We also need a psychologist and the physiotherapist, and we have to come to certain consensus saying that okay, this is what the mode of analgesia I would be using, and this is what the mode of physiotherapy you will be using. So how to correlate that if we are using the physiotherapy, the patient would not be having a pain. So that we can challenge that breakthrough episodes of pain by providing adequate analgesias. Then patient education and support. So that is very very important again. So we have to tell them about the pain management strategies which we would be employing, At the same time, some certain coping techniques also we have to tell them, because you have to always remember that we just really can't take out. We always say that we can take out 100% of the pain, but once it is a pre-operatively they are already having a chronic pain, then becomes a bit difficult to take out the entire component of pain from the patient, even though they have been operated. It becomes a bit challenging. So patient education and support is a very, very important thing. And another thing is that opioid stewardship, we call it as. So it's a key role of TPS, which helps patients who had been prescribed opioids for acute post-operative pain. And the important aspect is that we have to look into that we gradually taper these opioids. So why? Because this minimizes the risk of long-term opioid dependence. Okay, so that's why it is very, very important. Opioid stewardship is a big, important aspect because of this opioid prescriptions in post-operative pain management to home in the Western countries, especially in USA. There happened to be an opioid crisis, and that's how the opioids they stopped using opioids. So we have to balance that. So opioid stewardship again becomes an important aspect as a role of transitional pain services.
I agree with what you have said, sir.
Yes.
So you were talking about multimodal analysis. There were many like pharmacological and non-pharmacological methods for reducing the PPSP. But did you find in your systematic review any specific strategy that was most effective in reducing the post-surgical pain, sir?
Yeah, so it's basically the regional anesthesia technique, which is very, very important. Okay, so
Okay.
putting a preoperative epidural catheter or putting a block preoperatively again becomes important. So this has really played a very important role in getting down, I can say, the prevalence of PPSP in many of the patients, as well as the literature supports that. And also there is something called as ACT, acceptance and commitment therapy. This had shown a very promising results. So it is something like a cognitive behavioral therapy only, but it is a part of it where our psychologists will come with the transitional pain service team and will explain them uh, the importance of acceptance. Yeah. So something called as you have to accept your negative things. Yes, this is bound to happen, and this is there. Yes, it will, it is going to happen, and how to cope with that. So this becomes a very, very important, and I will say the psychologist has a huge role in this ACT. So actually, see, the TPS is very naive even in our country, and in my institute also we have not yet introduced this concept of TPS. So that's how I got this idea of doing systematic review and see what exactly is happening all over the world, and it may help our group of patients in our country. So that's how we started. The idea of doing a systematic review on this particular subject. So coming to that, so when we were doing a literature search and when we went through many of the RCTs, we found that in the Western countries, the introduction of TPS has resulted in a very significant reduction of opioid prescriptions. So in my study, I had stated that it almost 27.3% it was before the introduction of TPS, and it drastically came down to 13.4. So almost a 50% reduction of overall opioid prescriptions. So by introduction of TPS, so see how important it is. So it plays a very important role in opioid stewardship. And coming to the non-opioid techniques, yes, regional anesthesia is a non-opioid technique, right? We are using only local anesthetics in that. Many practitioners also add some additives or adjuvants in the form of dexmedetomidine or dexamethasone, clonidine. Many adjuvant medications are available. It is up to their, I can say, comfort level. But I usually use a plain opioid analgesics for peripheral nerve blocks. But for epidurals, I will say that you really need opioids for this group of patients. We just can't cut off opioids completely, especially for cancer surgeries in the form of thoracotomies, because it's a huge incision and they are in a lot of pain. So we really need some opioids, but we don't give it a systematic, but IV infusions, but we give it in an epidural way. So, and again, coming to local infiltrations, they play a very important role. Local infiltrations. I can say around 6-7 years back, we started using a pre-operative, or I will say a preemptive or a preventive analgesia component in the form of gabapentin, but we could not find any significant results in our group of patients, so we stopped using that because most of the patients were getting drowsy with that medication. So that's why, but that is also another form of way by something called as preventive analgesia. We call it as before the incision itself, we continue the analgesia and continue the same regime intraoperatively, but at the same time, you can add any other regime also. So that's the beauty of preventive analgesia. That is what we can do as a non-opioid. Certainly, speaking about ketamine and lignocaine, I have no personal experience for them to be used in acute pain services, but chronic pain, there is a lot of literature, and I use it in a lot of chronic pain. But for acute post-operative pain, I usually don't support that. But what we usually do is that we use a lot of IV magnesium rather than IV ketamine for this group of patients for acute post-operative pain management. So again, going opioid-free sort of analgesia. But I would certainly like to press on it that we still need opioids in certain group of patients. We just completely can't knock out opioids from post-operative pain regime.
And also, sir, like introducing a new service like the transitional pain service, there will be crisis in the staffing, the human resource management,
Yes. Yes.
and all these challenges will be there. And
Yeah.
what are the other challenges that will be there in implementing the TPS, and especially in a resource limited setup with high volume of cases? Also, there will be a lot of challenges. How do you tackle with all these things, sir?
So that's the biggest thing. And if you see my paper, that's the biggest
Yes.
limitation in my study, because I have not really looked into those factors of human staffing and all those financial aspects. I really not looked into that. But if you ask me, yes, it really adds on to the already ongoing burden of a pain service, which is really looking into acute post-operative pain. And then there is something called as chronic pain services also. So it really adds on to the burden, I can say that. Second thing is that staffing, right? So that is very, very important. So we really need a huge number of people. It is not a single person, it's an interdisciplinary approach. So you need a psychologist, or you need a nurse, you need a pain specialist, and you need an anesthesiologist also here
Yes.
again. So that is always there. But what I can advise as a solution to this aspect is that rather than going completely into the entire hospital spectrum, we can just choose one particular group of patients or group of surgeries which has more pain or more risks of developing post-operative persistent post-surgical pain. So identify those groups. It may be different in each institute. For example, if you ask me, in my institute, I will say the amputation and the post-thoracotomy pain is has a higher incidence of persistent post-surgical pain. So we can implement or we can, I can say, the extend the services of the acute pain services as a transitional pain services in that particular group, so that at least some burden will be reduced. Rather than getting hundreds of patients, you may have that particular group of only patients. So that is what is the solution I can give currently, who are already learning running a acute pain service. And if you look into that also, I have a paper, acute pain services in our India. There are very few centers who are actually running an acute pain services. So
Yes.
you just imagine, so transitional pain service may be still out, right? So so those who are running acute pain service can really think into that, and they can implement that slowly.
Yes, sir, I agree with you. As a closing question, someone who is a pain enthusiast or already practicing acute pain services, what steps do you recommend they should take, like to implement the transitional pain services? Like, is there any specific pathway to start the TPS from APS kind of a change?
So that pathway I had already put it in a I think a box pattern which is already there. I think the figure 8 in my paper itself. So I had given the steps how to go about that. So if I go back to my paper, I have to read that. So if you see that, So there is a pre-anesthesia checkup, and after pre-anesthesia checkup comes your transitional pain service. So that transitional pain service itself includes an acute pain service person, right? So then when you are discussing the modalities or you are assessing the patient, there comes your physiotherapist, occupational therapist, your psychologist and nurse practitioners, and they provide a rehabilitation to that particular patient. Surgery happens, then the patient goes into acute pain service, then they are discharged. So when they are discharged, then comes the transition. I can say the pain gap as well as the period gap. Okay, so that is where you need to have a periodic evaluation of this patient. So whenever the patient comes for a follow-up to the surgical OPD, you have to follow up the patient with your OPD also, and that is what I will call it as a transitional pain service. So this is what we can do, and we can follow this patient up to 3 months, because we label the persistent post-surgical pain after 3 months if it is persistent. So this is what we can do. I hope this made things clear.
Yes, yes, sir. Those were some wonderful insights, sir.
Thank you.
They build up more interest towards transitional pain service, and
Yes.
hope most of the many hospitals must implement it as a
Yes,
service like in the coming future.
I will say they should implement that.
Yes,
Acute pain service, transitional pain service.
yes, yes, definitely. So, as we wrap up, like I would like to extend my heartfelt thanks to Dr. Lakshmi, Dr. Reena, and Dr. Raghu for sharing their time and expertise with us today. As always, the Indian Journal of Anaesthesia continues to raise the awareness of cutting edge research and education in our field of anesthesiology. And thank you for watching till the end. And do not forget to like, share, and subscribe for more such insightful videos. And we'll see you in the next video. Take care.
Thank you. Bye bye. Take care, everyone, and good night.
Thank you so much. Bye bye.